on one sec.
This anticipation is killing me.
I know. I'm like, why am I not getting any audio here? Give me one sec. Oh, I think I know why. Huh. You guys can't hear music, right?
Nope,
No.
I cannot hear music.
All right, cool. Let me figure out what's going on exactly. How about
listening to?
Yeah, now you can, right?
Yep.
All right, cool. Let me restart this and away we go.
Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Hey guys, welcome to another episode of Civilian Medical Podcast. We're on episode 15 now. My name is Dietrich. I'm Skinny Medic on YouTube, and I have the Speed Demon Sean, and then we have Saint Fisher from Evidence-Based Medicine, the Wrecking Crew, with us today.
Hey, how y'all doing?
Good, man. Good to have you here. We had a little bit of an adventure trying to get you here, but now we're all here in the same place and ready to have a lot of fun, man.
I know. I needed the extra time, though, really, to kind of think about what I need to say and not sound like an idiot. So I'm ready.
That's actually my job today. I will be sounding like an idiot, so I'll be good to go.
Man.
We should start at the beginning, right? And just kind of tell us a little bit about yourself. Who are you?
My name's Andy Fisher. I am currently about to be, I guess I'm a fourth year medical student now at Texas A&M College of Medicine. I am also a PA in the Texas Army National Guard, and long road, but basically I've done a lot. I've done a few things over my career, and have been fortunate enough to be involved with a lot of great pre-hospital trauma care. And so I kind of maintain that sort of, persona on social media, trying to advocate for some, really great pre-hospital trauma care, from everyone from the physician all the way down to just the regular old person on the street, being able to kind of take care of people in bad situations. So, yeah.
That's awesome.
Go ahead, Dietrich.
I was just saying, yeah, that's kind of what we, our podcast, we wanted that for the average person to start that patient care, to start that continuum of care. Then when paramedics get there, EMTs get there, and then when hopefully they're providing good medicine all the way up to the trauma surgeons, it goes the full gamut. So that full chain of custody for the patient is what this podcast is hopefully here to help people do.
Yeah, that's why I appreciate you guys having me on, because it's hard to find specific podcasts that really kind of delve into this sort of stuff and get people thinking about how they can make a difference in overall patient care, whether they are a medical professional or they're bystanders. So it's a great opportunity. Thank you.
When you enlisted, was medical something that you were interested in, or did you get kind of thrown into it or fall into it, or how did that go?
Sort of fell into it. I enlisted as an infantryman. I thought that's what everyone did, honestly. I mean, I was such a knuckle dragger that I didn't realize that there was more things to do other than be infantry. And then I went to 1st Battalion, 75th Ranger Regiment, and then they sent me to an EMT course like in 1995. Like I'd been there few years. I was like a tab D4, and they were like, "Hey, go to the EMT course." I'm like, "Cool, all right." I don't know what this is, but it sounds cool. But I found out that I wasn't I wasn't a very good student growing up. In a lot of trouble. I think a lot of people who are in the military kind of have this familiar sort of story. Wasn't a very good student, got in a little bit of trouble, kind of wandered a little bit, and ended up in the military. And then you kind of find out that, okay, well, I'm not a complete moron. I'm still a little bit of a knuckle dragger, but I found something I'm kind of good at. And wasn't that I was a bad infantry person, but I was just really liked the concept of medicine. I liked the science, and I suddenly found an interest that something I really, really enjoyed. And so after that, I was like, man, I want to go do something in medicine. And that's what I did when I got out in '96. When I got out, I worked as an EMT when I went to Indiana University.
Did you work on an ambulance as an EMT, or what did you do there?
Yeah, I don't know how I lucked into this, but because you read about the people, on social media, they have to start working out in these IFT services and private services and this. I kind of just like fell into this. It was a it was mostly 911 service, but they also did the transfers. It was, Bloomington, Indiana, there was only one ambulance service. And so they did a little bit of both. But there weren't a lot of like inter-facility transfers. But so I just fell into 911. And then after that, I went to Wishart up in Indianapolis, which was all 911. And so I really don't know what it's like to work on the private ambulance service side of things. And I don't feel bad about that. I just I feel more for the people who kind of get stuck in those situations, and for people that want to work in the medical field, something like in EMS, and that's where they have to start out. Like it's so difficult to find a 911 position. At least it appears that way.
Yeah, at least where I'm at in upstate South Carolina, like even the 911 services are really hurting. So if you're an EMT or paramedic, you can get right onto a 911 service. And for me, I started 911 too as well, and I started a little small service, and then I went to a larger service in South Carolina. So did a lot of inner city stuff like 911 thing. That's how I got into like the trauma side of medicine for EMS. But yeah, so I mean, I hate it for those people who get stuck in that rut of private service, because that's not what EMS is fun. Like I love my job, and I still love EMS. I'm still a little like nerd for EMS things. So that's not what EMS is really designed for. I mean, it has its purpose, but there's more fun stuff to do.
Yeah, I hear you.
That's awesome. Yeah. So PA in the National Guard now. Tell us about that process and how you fell into that.
Again, here I am, a medical student at 46 years old. But I just kind of keep on thinking I want to do something else. And in 2003-ish, I was coming to the end of my college money, my GI Bill for my initial enlistment. And this was pre post 9/11 GI Bill. So kind of running out of money. I was like, I don't know what I'm going to do. And I was still in the National Guard as a medic then, because I had changed my MOS. And I was like, well, man, I guess I can go to PA school. That'd be cool, because I remember that, Doc Donovan, like Chief Donovan, legendary Ranger PA. He was my PA in 1st Battalion, and man, he was such a rock star. Like when you thought about people that, this guy was, 18 Delta in Vietnam. Then he came to Ranger Battalion as a 18 Delta. And was like the senior medic. He went like the PA school. He jumped in Grenada. He jumped into Panama. I mean, when you think about overall just badasses of pre-hospital military medicine, Doc Donovan is at the top. I mean, I literally cannot think of someone else I'd put up there higher than him. So I was like, man, he was pretty awesome. So I think I want to go to PA school. And so that's what I did. I applied, and somehow I got in. And then so I was in the Indiana National Guard. And towards the end of PA school, I was like, man, I'm going to go on active duty. And the National Guard, especially the Indiana Guard, did not like that at all. But it was during the surge. So this was 2006, at the beginning of the surge of everything. And active duty was like, we need PAs. We need a lot of PAs. And so I don't know what happened, but they worked a deal, and I went on active duty.
Very nice.
Yeah. But then I went to Korea for a year.
Oh, man. Some medical school, that kind of a big deal. It takes a lot of time, I imagine.
Yeah, I tell you what, it's a far more difficult I don't know if it's more difficult than I had anticipated, but I think I struggle. I struggle in areas where I didn't think I would struggle. I guess that's probably the best way to put it. Very difficult. These kids are incredibly smart, super, super smart people. When I see people talking about medical students, kind of the dumb things they do and this and that, I'm like, yeah, that's pretty anecdotal, man. You got to see some of these kids, man. The stuff that they can remember and they can knock out, and the things and that they come up with, and the plans for patient care. Really, really smart people, and really kind of brought a new, really huge appreciation for every doctor that I ever worked with and worked for over the years.
Absolutely. That's one of my side jobs is I help teach at the GHS School of Medicine. So in Greenville. And so when those medical students come in their first year of medical school, their first semester, they get their EMT and they ride on the ambulance with us and stuff like that. So they can follow patients from the house to discharge if they choose to. So I say the same thing. You know, those medical students coming in, especially their first year, they are so freaking smart. Like they will have the book read and memorized before class. And like I joke and say they're so smart, but they know absolutely nothing. Like they're smart, but then I can teach them like how to do a patient assessment, like or blood pressure, and they're like, "Oh my gosh, this is so cool!" And but they're a blast. Like I love teaching the medical students. It's different than teaching any other EMT basic class I've taught, because most EMT classes I've taught are for, firefighters or people looking to get in the career, and not saying anything bad about them, but these kids are microbiology, whatever is their undergrad. They're so smart, like they want to know more than just what an EMT is supposed to be taught and understand.
Yeah. I completely agree. I think just like EMTs, they lack some of these common things that we take for granted. I think things like simple patient assessments or something like taking a blood pressure. But once they kind of get those skills, they quickly put it together. So,
absolutely. I mean, they'll have the skill checkoff sheet memorized, and like they just have to roll through it. Like, all right, let's go through it. The funny thing we've kind of figured out is like the M1s come through and they get their EMT, and by the time they're M4s, we see them again and we teach them ACLS and PALS. So they've gotten so much knowledge now. Now we go back to the basics. We're like, all right, remember your airway, breathing, circulation. Like you've got all this stuff going on in your head, but let's go back to the basics.
Yeah. That's awesome, man. Great to hear.
So let's change gears here and start talking about TCCC. You are on the committee for TCCC. Can you tell us about that and how you got there?
Yeah. So again, being a PA, so after I became a PA and doing Korea, then I submitted a packet to go back to the 75th Ranger Regiment. And so I had that opportunity, and I served there for 9 years as a PA. And while you were there, there are people that were on the committee that from the beginning that were also in the Ranger Regiment. People like Colonel Russ Cotwall, Master Sergeant Harold Montgomery. These really legendary guys. And so you get to work with the committee pretty closely. You get the opportunity to get invited to the meetings, because it's not an open meeting. They only have so many seats. But you get the opportunity to go maybe present something at the meeting, or maybe you share something. And so you end up building these relationships over years. I think my first meeting that I was invited to was after Corey Remsburg, after he was injured. My medic, Brian Rippey at the time, was invited to go do a patient kind of vignette of these casualty scenario there. And so I went with him, and we presented, and that was in 2009, I think. So I've been affiliated with them since about that time. Once I became a medical student, I was nominated to join the committee. And that's a process to where it goes before they have a whole committee, little subcommittee of who decides it's going to be on the committee. There's only 42 people on it, and it's made up of physicians, PAs, has scientists like PhDs. You have but the great thing about the COTC is that has medics, PJs, corpsmen. We have to have a certain amount of those people on the committee, and so we have overall, like I said, 42 members. Everyone has been deployed. That's on the committee at this point. We have some active military, some retired. We have some in the reserves and National Guard, like myself, and it's kind of an overall place where basically what TCCC is, I like to say, it's more like their clinical practice guidelines. So basically, we take all the evidence. Hold on, I think I'm probably digressing a bit. Do I need to start over? Sorry.
No, it was good.
Yeah,
I'm totally fine with the way we're going.
Okay. So yeah, what we do is we take concepts, stuff like Care Under Fire, and Frank Butler, Captain Frank Butler, developed these, the initial paper back in 1996. And so it's the same sort of concept, but we kind of take a look at the overall evidence that supports that practice. So if we decide that, as been decided since 1996, that the only thing you should do in Care Under Fire is apply a tourniquet. Okay, well, let's look at tourniquets. And we just got done with a huge tourniquet review. Took a couple years to complete. And, we're still working on the actual paper that will kind of discuss it. But we basically take the best evidence that we can find out there. We do an evaluation of that evidence and then produce what we call clinical practice, the basic clinical practice guidelines, what we just call them TCCC guidelines. So I basically say, hey, this is what we think works best, and here's what we recommend.
I'm really excited for that paper to come out. I want to just have the paper come out. I want to sit down with a cup of coffee and read it. I'm looking forward to it.
Same. It's definitely something that people have been really asking us a lot of questions about, like, when are we going to see kind of what their process and procedure was, what the results were, and that evidence-based results of that.
Yeah. I tell you, so I was on the working group that worked on that, and it was it was exhaustive. It was, like I said, very long. There were some very well-known and respected physicians, medics, researchers on that group, and then once you develop that, it goes before the whole committee, and the whole committee has to vote on this, and it's a simple majority for that. But I'm sorry, I don't think it's a simple majority. I think it has to have a certain percentage. So I don't want to say that it's a simple majority. I mean, I don't recall off the top of my head. So
it seems like there's a lot of talk about the difference between recommendations and suggestions and all these other things. Why is the distinction important?
That's a great point. I still feel like I try to address this often on social media. A lot of people talk about approved versus I saw something the other day. It said certified, and these are just, because they're clinical practice guidelines. If you, in medicine world, guidelines are nothing more than a way to, hey, this is what we think is probably the best way to go forward. This is a recommendation based upon what, the evidence and the subject matter experts, we all kind of crank this thing out, and this is what we think. It's not the approved. We don't prove anything. We don't do research. We have people within the committee that do research, but the committee just says, hey, here's what we think is best. And that's across the spectrum when you look at medicine and what we call these clinical practice guidelines. That's what physicians and researchers, and what they do is they put these together and they put it out to a group of whomever, doctors maybe. I mean, if you look on there's a whole bunch of clinical practice guidelines for the U.S. Army and for the DoD. And it's just saying, here's what we think works.
How do you think the TCCC guidelines can relate back to civilian world, like civilians, how we can, because correct me if I'm wrong, we're talking about, military age men and women here, correct? And now how does that relate to the civilian population?
I think, so if you look at, say, something like Stop the Bleed course, that kind of uses the same evidence as we do in the military, and that's because that's really the kind of the subject matter experts of all this pre-hospital trauma care. And that may be partially because we don't have all the necessary evidence like we do in the military. Maybe we don't have the effort or the time in order to kind of create those guidelines and kind of do the research, or maybe because maybe what we have is, like I said, the kind of the best stuff out there. I think it relates in a way that is great evidence, and it is it is based upon the same, like I said, approach that every other kind of medical professional sort of approach to identifying best practices, and it's relatable because people bleed out. People bleed from extremities, and there's still the best way to kind of go about that is maybe with a tourniquet, maybe with some sort of hemostatic dressing. There are some limitations though, like we don't have a lot of, say, like the morbidly obese people that we may see in the civilian world. But we also have seen people like you and others kind of come together and come up with different ways to approach that, right? So we've seen people talk about strapping 2 tourniquets together and using that as one larger tourniquet. So we kind of see people do working ways around where maybe our guidelines are maybe a little bit limited.
Yeah, and just being a little more. Yeah, like that's always been an interesting thing for me. Is like, all right, look, how do we address someone who has high cholesterol, diabetes? Maybe they have AFib, they're on blood thinners, things like that. That's all going to increase how the patient reacts to losing a large laceration or a cut, something like that. So, trying to show that and be open about it, because there's more than one way to skin a cat. So, to being open about maybe this tourniquet works, maybe it doesn't, maybe it's better than a belt. I mean, that's kind of where, like, I've tried to be there, but I've missed the boat sometimes as well. I've when you learn things too, go back and like some of my older videos, I'm like, golly, that was old, and people are like, oh, that I've learned new stuff since then. Things have changed since 6 years ago.
Yeah. And I think that's important to recognize that, yeah, things do change, man. We do find more evidence. And that's why we try, and I'll be honest with you, and I think the everyone on COTSI will probably say that we were probably late doing a tourniquet review, right? But you see, like, we crank out updates, twice a year, always going back and kind of relooking stuff and saying, hey, what has changed? So it's probably it's great that you recognize that, man, is that what we were doing 6 years ago or whatever, and that practice has changed then. And I don't think there's anything wrong with recognizing that. In fact, it's probably something that you could point to and say, hey, here we are. We're really trying to stay on top of what is right. We once believed that, pushing normal saline was what you did for trauma patients.
2 large bore IVs,
right.
Like you just floated in there. We made Kool-Aid.
Right. And I'm guilty of doing that. And so along with 99.9% of all paramedics that, before probably 2005, 6-ish or whatever, but we know better now, and we can look back, we can keep that, and we look back and say, whoa, let's not repeat that.
Exactly. Even for me, like when I first got into EMS, it was, all right, we're going to apply direct pressure to this arm or leg. You're going to elevate, you're going to use a pressure point, and maybe you think about calling a doctor for a tourniquet. Like a tourniquet was absolute last resort. And now it's like, oh, okay, let's just put a tourniquet on that and move on. This guy's got other problems. They'll fix it when we get there. So the trauma care has come a long way. Yeah. Even the last 5-10 years has come huge.
Yeah. And I'll be honest with you, I think we're probably applying too many tourniquets in the civilian world. I think what we've done a little bit is taken this idea of care under fire in the military, which is just go high and tight. And kind of move off the X. And now I think what we've done, we've probably transitioned in a way that we're saying, hey, just put on a tourniquet, it doesn't matter, put it on high and tight, instead of maybe taking a little bit slower approach and teaching people to how to recognize when a tourniquet needs to be applied and where a tourniquet needs to be applied. And I think that's probably important that we, moving forward, I think that's probably where we need to go for people, teaching people like bystanders how to do things, how to perform these life-saving interventions.
Yeah, and I think you're dead on about that. Is we do really focus on the high and tight and move on quickly, but at the same time, when you're talking about a civilian who comes in and takes, like, a 1-day medical class and thinks about it, that kind of thing, I think, does stick with it. So I think it's very important in any further training that people take. The first interaction you have, high and tight, think about that. And then anytime they put any more effort into learning and things like that, to really delve down and focus deep on it. Because it's just like firearms training. People go take a concealed carry class and then never really think about it again, and then have to draw their gun, and nothing is planned, practiced, or anything else. What would you say to that thought?
I think having this feeling that bystanders who come in for an hour, 2-hour course don't understand what 2 to 3 inches above a wound is somewhat. I think it's insulting, honestly, and I think that people are smart enough to recognize where a wound ends and where they need to put a tourniquet. There may be some hesitancy about, hey, is this the right wound for a tourniquet or not? Now, maybe that, as they kind of continue their practice and training, they become more familiar with that. So I think we'll probably see a lot of early application, but I think the idea of applying high and tight from the, things like just standard bystander hemorrhage control courses, I just don't agree with it. I think we can teach people how to apply tourniquets properly.
I love it.
Yeah, for me, like, I see it a lot, with, we'll pick on police officers for a minute. We'll get out there and the officers apply their CAT, which I have a problem with that, but they applied their CAT to a civilian, and it's like, all right, we probably could have used direct pressure to control this bleeding. And in our protocols, we're able to take it off and go, all right, let's just evaluate this and take a look at it. If it hasn't been on for very long, we can take a look at it. But yeah, that's, officers are, they're being quick about it now, and police officers are being more proactive with medical, at least in my area, it seems like. But there again, that recognition of what is life-threatening bleeding. And I agree with Fisher, to say that, look, if someone drops a chainsaw on their ankle and it's a nasty wound, there's no reason to go up to the pelvis. Like, there's no reason to run that CAT all the way up to the pelvis. We can put it on a few inches above. And I think, talking about retraction, like, I remember being talk about, the femoral artery retracting 6 to 8 inches back in the pelvis. And I remember Fisher, I don't know if it's on Facebook or Instagram, you said that. You're like, no, it doesn't happen. There's no evidence to support that. I was like, interesting. Like, it was a stupid social media post, but I remember reading that. Yeah,
like can someone point out to where it retracts that far?
Black Hawk Down.
Exactly, that's their evidence. You're like, well, we've seen this movie once. Yeah. But yeah, and that's, I think, also a problem sometimes is as I'm parodied by some pretty funny dudes, that a lot of pre-hospital professionals who are out there teaching this stuff don't really understand how to appreciate the evidence and anecdotes versus the research that's been done. And I think that's probably an issue that is probably not only EMS, but I think is a problem, that if we're teaching civilians how to do certain things, we should be able to understand what is right and teach them what is right the first time.
Love it. Can we talk just real quickly about the process of testing? I mean, you guys do evaluate a lot of products. Especially just recently, we saw the tourniquets come through, and without sharing anything that you're not allowed or willing to share, can you just talk about, is it, do you test with Doppler, or what does that process kind of look like to just the layperson?
Yeah. So how COTSI evaluates?
Yes.
Tourniquets? Okay. So basically, we for any sort of process, really, what we do is we gather all the research, published research, right? So we take all this published research, we kind of read over it, we kind of lay out, what the findings were, what did they test, what was the primary outcome, what was the secondary outcome, what were the results, and what were their conclusions, and also importantly, what were the limitations of that study. There are, for instance, the tourniquet one, there are just for, I think, this review, there were over 100 articles, tourniquet research articles that were used. I didn't count the ones that weren't used, just based upon, like, we didn't use things like anecdotal, like, hey, like case study, like, hey, this guy used a tourniquet for this long, and or in this type of scenario. We didn't use that stuff. So this is all like research stuff, both clinical stuff. So we use clinical stuff. So if you happen to use like John Craig and the stuff you published from Iraq that said, hey, we got all these tourniquets that are being used on these guys. And look at, hey, we saved a lot of lives, and that's fantastic. And then we had people like John Craig also, who are out there down at Fort Sam Houston, now retired, cranking out this studies where he kind of simulates different scenarios and kind of evaluates tourniquets and stuff like that. So there's a lot of different, there's both clinical studies, and then there's just like this bench work. It's not really bench work, but yeah, we take all this data and we kind of put it all into the same thing, evaluate every single one the same way, and then we kind of see what those outcomes are. And based upon that, then we take a small subgroup of the committee and we kind of say, hey, all right, let's take a look at this and let's kind of form what we think are the recommendations. And once those kind of recommendations are all formed, they go to the committee for a vote. And like I said, I don't remember the exact number that is needed to approve something, but everyone gets one vote.
Wow.
And then, so the tourniquets have to be able to be applied one-handed, correct?
I'm not so sure that's a very important. I don't think it's necessarily very important.
Okay.
I honestly, I can't remember if that was I can't remember off the top of my head if that was a criteria. Obviously, if you saw Monty briefed this at SOMA, and it was, there was a lot of criteria, like probably 10 different things, and there were like almost 20 tourniquets. So there's a lot of data, and I don't remember if one-handed was there or not. I just don't think it's that important. I mean, how many true cases of one-handed tourniquet application have occurred in the last 20 years? I just don't think it's a lot.
Yeah,
makes sense.
So I don't know.
I think especially for the civilian side, like I don't know if a civilian, it's like I think they're probably going to come up on something, or they're going to have both hands free to be able to apply the tourniquet. So that's kind of that's why I was bringing that up. It's just curiosity for that reason, because like I said, I don't know of any civilian that I can think of that's run, that's applied to an arm that I've run in the field. They've applied it to someone else. There was someone else on the side of the road they applied it to, or they were in the field, stuff like that. So that's why I brought it up.
Yeah. I mean, I've heard of cases, but I just don't think it's a very large cohort of people that have had one-handed tourniquet applications.
Makes sense.
Yeah.
Let's move on, Diedrich.
So, we've done stuff, I've seen stuff on Instagram, YouTube. Anybody and their brother's able to post on YouTube. I prove that. Now we're starting to move towards this evidence-based medicine. And I think I don't say your group, but your gang, whatever, kind of really started this motion. It seems like about 6 months, a year, like they've been really starting to push, like, show me the evidence on this, show me like how it works, and why is that important to the civilian people? Not just look and say, this is the way we've always done it. Let's look at something that why has data behind it.
Yeah. So I know that I particularly became very, I think, involved with kind of pushing what do we have for the scientific evidence that suggests this. Probably because it's all because of my own mistakes. Most of the things I really harp on in medicine or in my life is usually because I've already made that mistake, and I just don't want to see people make the same mistakes. And I think that's probably true for a lot of people. I remember that I've been called on some stuff when I was recommending, bad, non-evidence-based anecdotal stuff, and I have learned over the time that medicine, as I evolved in medicine, that really, I mean, if you look at how medicine is practiced and how it initially was practiced and how they did studies, and then as we moved towards, becoming more evidence-based, that happened in the 90s, We got better at both doing studies, conducting studies, doing them ethically. Like the United States and most countries didn't always have, very ethical studies. And that's unfortunate that a lot of people were subjected to, treatments being withheld for their disease, or they were given things that weren't necessarily appropriate. And that's sad. That's a sad part of our history here in America. But like I said, a lot of other countries have done it. But we learned and we fixed ourselves, and now we have a very stringent approach to research. And we don't just use a case here and a case there, as we say, anecdotal evidence. It's great that anecdotal evidence can maybe start a question. And so we publish these case reports and because they can make us start thinking about something. Well, hey, maybe we should think about, the tourniquet being applied here. I'm going back to tourniquets simply because it's something easy that everyone can relate to. So maybe we apply tourniquets in this sort of situation, and we apply it like this. Maybe we should use a windlass. We should tighten it down and get that mechanical advantage. And that kind of gets us moving down a pathway to where we start having these, this laboratory type studies, and we kind of see it moved into maybe a small cohort. And different ways to kind of overall approach medicine. And like I said, I've learned a lot, and I kind of try to help people understand that we have to have an overarching, better understanding of what everything says. And there's a hierarchy to how evidence is graded. And case reports and anecdotal stories are at the bottom.
I agree with that. I like to see, I love the fact there's multiple tourniquets on the market to prove from. We'll say tourniquets, that's what we're on. Yeah. There's multiple for you to choose because the market's wide open right now. And I love to see new tourniquets come about. But then, we're at SHOT Show and a new tourniquet comes out and it breaks, right there on video. So you've got to be able to say, look, that's a great idea, but let's take a look. Let's spend some time with it in a lab, in a control setting to make sure it's going to work. And then we can take it out and to look at that data behind it, because the perfect tourniquet is not on the market right now. I don't think so. I love the cats. That's my tourniquet, and it's not perfect. It has failure. It has issues.
Yeah, every tourniquet has what I'll call an acceptable failure rate, right? There is no such thing as a tourniquet that works every single time in every single patient in every single scenario.
If we could come up with that, we could drink beer together on a beach somewhere.
Yeah, seriously. I mean, cat tourniquets fail, soft T's fail, TMTs fail, RMTs fail. I'm trying to think of the tourniquets. The SAM XT fails, and so they all fail. And just because a tourniquet wasn't necessarily recommended doesn't mean it doesn't necessarily work, right? So there are tourniquets that were not recommended that will come out in the paper. And it shows, hey, here's why it wasn't recommended. Maybe it's because there wasn't enough evidence, and not because it doesn't necessarily work, but because maybe it hasn't been tested enough to kind of build that base of saying, hey, this does work. And there are tourniquets out there that report having thousands of applications, but they aren't. But that doesn't tell us anything. That doesn't tell us that saves someone's life, right? We kind of need the medical records throughout on those cases and kind of say, hey, yes, this was applied, that this has resulted in this. And that kind of provides us overall if things maybe work in those kind of clinical scenarios. If we're doing like retrospective studies or something like that. Yeah. Yeah. So it's a difficult position to take because it's often not it isn't very popular. At least I still don't think it's very popular position to take. There are a lot of, I think, probably heated discussions. I think sometimes there are people who get upset, and certainly, I'm not immune to that. I've been offended. Probably, I probably said things I shouldn't have. But I think that's part of it. And I think as long as you can accept that people do kind of lose it every now and then, but just, okay, got it. Hey, let's move on. Let's talk about the next topic. Maybe admit that you kind of screwed up. I've certainly said, I've apologized on social media many times when I've been wrong.
And I got dragged into some stuff like right before like NRA and Soma. Like I had guys wanting to meet me. I'm like, good gosh, people, just because I said, I don't like this tourniquet anymore. I've kind of, I don't recommend your tourniquet. Like crazy stuff.
Yeah. And I'll tell you, often, like if you look at things like, here we are, tourniquet still. A tourniquet may work, but often we kind of look at things like how can we apply this to the overall population. So if I give person X A, B, and C tourniquet, will they be able to apply them consistently, properly? And that's not always true, and that's also some of the reasons that you may not see a tourniquet recommended. So
I agree with that.
Yeah.
The one we're kind of beating around the bush talking about, like if I'm sitting in a classroom, I can apply it using Doppler, and I can get my blood flow to stop. But giving it to someone else, giving it to, in a obscure environment, stuff like that, like it's just not going to work, or it could be difficult to get it to work. And so why not choose the best tool for the job, or the better tool for the job when you can do that?
Yeah, I'm talking about like 4 tourniquets right now.
I got like 3 in mine, so you got one more. I mean, I've got like 3.
And that's only because I was part of the group that kind of evaluated all these things, and again, I was attacked on social media, but at the same time, man, talking with people who were associated, it was all cleared up. Like I don't have any ill feelings towards anyone. But I don't know, like there's just a lot of there are some studies that there's a lack of data in some areas. There's just an overall, when you look at what else is out there, sorry, I digress again.
No, not at all. It's good.
No, I mean, like for me, like I got threatened with lawsuit twice during all that stuff, maybe 3 times, but I was doing pretty good there. I was on a roll.
Yeah. I'll be, hold on. Can we take a break for a second? Timestamp this. I don't know what is, so this doesn't go in timestamp. That's like, I don't want to drag out the whole rats thing.
Yeah, no, again. I don't want to. Yeah, I agree.
So I don't know where we need to cut that off. Like whatever. Like I said, I really don't hold any ill feelings towards, that group. And Jeff, like he signed over the websites to me and everything.
Nice. Good to hear.
That was some bull crap.
But yeah, I did. But I don't, it's almost like I just don't care.
Yeah.
So so I just want to timestamp this. I don't know where we need to stop on that. I just don't care.
Yeah, I agree.
I get it.
Let's move on to like where it says recommendations for civilians. So kind of like if someone is building their trauma kit, like we can kind of talk about that.
Yeah. I do have one more question on the other stuff, not related directly to that. Let me just give a moment of silence here. So knowing what you know and being where you are and seeing all the different things that you have seen and still do see as far as product evaluations and things like that, if a company was going to bring a new tourniquet to market, how would you recommend for them to kind of go about that? How would you recommend that they get the right buy-in and provide the right data and do the right things so that we don't see some of the just train wrecks that we have seen maybe in the last few years?
I don't really know I'll be honest, I don't think I know the best way to go about it. I know that people have reached out to me over the years, and it would, be nice to be able to, just simply just do a study real quick and kind of evaluate things. But part of it, I think, is, reaching out to people probably like, Colonel Craig and stuff. And he does a lot of great stuff. Like he'll evaluate a lot of different tourniquets and does some just phenomenal work. And so I don't know if it's maybe trying to reach out to the ISR or if it's maybe trying to reach out to look at these, if you do like a search for, people who do tourniquet research, reaching out to them and seeing if, hey, I have this tourniquet. If you're going to do a tourniquet study anytime soon, please consider my tourniquet. And it eventually gets in there. I can think of, there are very few tourniquets that I can think of that haven't been in at least one study. And that's kind of the way it goes about it. It's just kind of getting it out there and getting it into these laboratory studies that maybe if you can show that they work, maybe you get people, police departments or something like that, that'll buy it.
Makes a lot of sense. Yeah.
And then you start collecting clinical data, and from there it just kind of grows.
Yeah. All right, perfect. Dietrich, let's move into that next segment.
So I'd like to, while we got you here, just kind of talk about, say, you got an average guy, gal who maybe goes to the range or this want to be more prepared. What kind of equipment would you recommend these people carry? Average guy, very little. We'll talk about classes in just a second, but maybe we're just getting started.
The average guy, average girl guy, just kind of hanging out.
Yep, just civilian people who may go to the range, shoot, train, whatever.
I think there are some pretty fantastic kits out there that are pre-made, and I have no financial, gain at all, or no disclosures to make financially wise, but North American Rescue Group makes great little kits. TACMed Solutions makes great little kits. I think it's honestly better for someone in that situation to buy something that's kind of already put together instead of trying to put something together. And once maybe they buy two and they practice with one, and maybe once they become familiar, they can have a better understanding what they think they should carry. Maybe they need to plus up on tourniquets, or maybe they need hey, I want to carry more hemostatic dressing.
That was my next question, actually. Do you feel like the average person needs to carry hemostatics, or is compressed gauze good enough for them?
Oh, man. So if you look at the stuff we cranked out from Iraq and Afghanistan, we didn't find. Now, again, there are limitations. One, it's retrospective. Two, the numbers are kind of small. But we didn't identify any survival benefit with hemostatic dressings. What does that say? Again, it's retrospective, so it's kind of hard to, you can't really do a correlation, or you can't really do causation. You can have a little bit of correlation, but you really can't do causation. And like I said, the numbers are kind of small. We do know that they're used in casualties or patients that are more critically injured. So that may just be that we have these injuries that maybe they get in a tourniquet, but also have another wound that they get a hemostatic dressing put in. I don't know. I like to think that based upon the laboratory data that they do work and can help you decrease mortality. But I'm going to say right now, what we know, I don't know if there's a big difference. And we do know that, gauze or the hemostatics cost more than traditional gauze by a lot.
Mm-hmm.
Yeah.
What about chest seals? I know, like for me, like I think getting the size holes that it takes to make a true sucking chest wound can be, a little bit more than what we think, the average person sees. So, do you think it's a good idea for someone? I mean, obviously, for a civilian applying chest seals, or?
I have no issues with civilian applying chest seals, but I also think that people need to understand that we're probably not saving a lot of lives with applying chest seals. As you said, there are very few that actually are like sucking chest wounds, right? So I don't know, but it's not necessarily I don't think it's a harmful skill, risk benefit. I don't think there's a lot of risk associated with it.
Yeah, that's kind of what I agree. Like I agree with that statement. The fact that when I teach my classes, I'm like, look, if you can stop the bleeding on the tourniquet, that's fine, but you can't do anything for the chest injury. Someone's got shot with a 9mm in the center chest, they need a trauma surgeon. So you've got to get them out the door to the trauma surgery fast. Yeah. So being able to prioritize those patients to the front of the line, I think is important.
Yeah. I think it's the idea of things like chest seals, MPAs, and needle decompressions. I think right now, maybe getting into things like into the law enforcement, and especially like SWAT teams that can maybe perform these critical skills, especially like something like needle chest decompression. That will definitely save someone's life. and then maybe move from there. I think if you do look at like I hate using the idea of active shooters as some sort of way to get people into seats and get people trained, and thinking that's why it's important to learn these skills, because we all know that you're more likely to have a car accident or something accident at work.
Yep.
But accidents do happen. Accidents happen on ranges. People are accidentally injured there. So yeah, do we have a skill set moving forward that goes beyond what Stop the Bleed is? I would like to see it someday. I just don't know when. But right now, chest seals I think are very low risk.
Awesome. You kind of brought up Stop the Bleed. So obviously, I posted an article in my group Facebook, and you immediately commented on it, and I agreed 100%. The article was written, and it mentioned our podcast, which I thought was pretty cool.
Yeah.
Name the classes that you should take. I think everyone should have a CPR and Stop the Bleed class.
Yes. Minimum CPR, Stop the Bleed. I don't see why EMR, emergency medical responder, would necessarily be something that is that you shouldn't be able to take. I think that's fine. Wilderness medicine or wilderness first aid or whatever the different wilderness medicine courses are out there, I think are fantastic. I think people taking TCCC courses that are non-military, I don't necessarily think that's a great idea, because there are very specific concepts there that are uniquely applied. And that's kind of like how we initially talked about, like, hey, we're just applying tourniquets high and tight because, and I think that's part of what has happened. So I don't know if it's a great course for just people to take. It doesn't really have a lot of applicability. I think that TECC is a much better course, but still, I believe it's more of a EMS, firefighter, law enforcement course. I don't see a big reason why people need to have all these tactical courses, simply because it's not a very likely scenario that you're going to find yourself in this situation. And even if you are, what are you going to do? Look at all these situations that have happened over the years, and where has a bystander used all these critical TCCC skills or something like that to do something. And so what did they have that in a TCCC course that they wouldn't have gotten in a Stop the Bleed course? And so that's my kind of thoughts on that. I know it's my own opinion. It's kind of what I believe.
I actually do agree with you a lot there that, I've taken several, I am not military, law enforcement, anything. I've taken multiple TCCC classes. I think I got a lot out of them, but ultimately there's so much there that just doesn't apply to civilians, that may be risky for civilians to do. And yeah, I think that things that are more focused specifically on possible wounding epidemiology for, traffic accidents or, just household stuff or, industrial stuff, I think that focus is so incredibly important.
Yeah. I think the like I said, there are penetrating injuries that do happen. So there's nothing wrong with knowing about it, but I just don't. I think people kind of fantasize the whole concept a bit, and it's just not very applicable. And I do get worried, like I said in your group, that we do have some people out there that are teaching these courses. Like you go to a 2-day TCCC course, and the only thing that you can comment about whenever you come out of there is how to apply a tourniquet. Then we've missed about 90% of the course, and that's, I think, is a problem that needs to be addressed.
I agree. Like for my department, we teach TEC classes, and we go to the fire departments. We'll teach those classes as well. I've helped at North American Rescue doing the TCCC classes there. I'm not military like Sean, but I'm like, I can come in. We'll talk about patient assessment, stuff like that, because that doesn't But I'm not going to teach you how to breach a door. Like I'm not the best person to get into to breach a door or to how you're going to attack this wall. Like I'm not the best person at that. Yeah. But I think if someone took, a Stop the Bleed course, took a CPR course, I'm not a huge fan of the AHA and other basic first aid courses. They're a lot DVD based, and they're just not getting a lot of hands-on. So I do like if your time allows that EMR time, you can get that class and, take that course as well. Because to me, the last few classes I've done with the AHA stuff, it's all video based, and that drives me crazy. Like I just don't think you're getting a lot of hands-on training there.
Yeah. I'll tell you what, I should mention, like, First Care Provider
Yes.
does a fantastic job. They are just really kind of doing some really cool stuff. And I cannot say enough good things about them and what they're doing. So they are also I don't know if your listeners know this or not, but they're also kind of Stop the Bleed is kind of like a concept. Like, they have the Stop the Bleed course, but they also, Stop the Bleed is just the Stop the Bleed campaign. So it's an approved, like, Stop the Bleed type course by the DHS, and that's the way it initially started. But yeah, they're out there doing some awesome stuff, man.
It seems like to me like their course is stepped up above Stop the Bleed and kind of does do some different concepts. So I like the outline of it.
Yeah. And I am chairman of National Stop the Bleed Month, and I talked with Josh. It seems like I talk to him all the time, but man, what a fantastic guy, and always a joy to talk to and discuss kind of the overarching concepts of bystanders learning how to control hemorrhage. He sent me a picture the other day on text about one of their instructors not using any videos, just outside with these kind of handouts, kind of these flip cards thing, going through and teaching people how to, control hemorrhage. So I think that, like I said, no one wants to watch videos all day. So a way forward maybe to kind of figure a way out how to do it outside, with people and more interaction.
Love it. Let's see, where are we at here? Civilians, from our perspective, just kind of being out here and seeing the feedback that we get from the show and from Skinny Medics YouTube channel and just medical gear outfitters and everything else that we're involved in. Dietrich and I both have seen what we consider to be a huge jump in civilian interest, at the very minimum, of taking these kind of trauma classes and these skills and these kits and all these different things. What do you think that the future holds for both civilian involvement and just the future of trauma care in general?
Like I think previously mentioned, I think we'll probably see maybe some more skills brought to the forefront. While the likelihood of being an active shooter situation is rare, it's the stuff that Reed cranks out with the penetrating torso trauma and these active shooter situations, I think overall may help us kind of identify a way forward to developing curriculum for the bystander to be able to, like, is it chest seal, or do we eventually have training that allows them to perform something as invasive as a needle chest decompression? I don't know if we'll ever get that far, but I think having those sort of concepts of how do we address these things, is there something that they can do, I think is probably the way forward.
Awesome.
Yeah. I don't know. Yeah, it's I think we'll probably I'd like to guess also see maybe a little bit more integration, maybe between something like a Stop the Bleed course, maybe something like CPR. And I know a lot of people already do it, but moving forward, is there a way that we can maybe create a hybrid type course and knock everything out at once?
That would be nice. And I think that's what I do like about the First Care Provider. They're trying to, instead of me teaching my way, everybody is like they're trying to form a standard of how to teach these courses and stuff like that. Everyone teaches the same stuff. So I like that about their program.
Yeah, absolutely.
So for someone who's 16, 17 years old, who's thinking about getting into military medicine, got any advice for them?
Wow. People want to go into military medicine. I am completely biased, but I believe that being a Ranger medic is probably the best job in the military.
All Rangers say that.
I know, but I admit my bias, man.
You did.
I tell you what, man, they just I love those guys. I just working with some of the most fantastic people who are clearly much smarter and brighter than me. It was just a great job, and the stuff they get to do, the schools they go to, and the guys they take care of the guys. Great job. I think special operations is a great place. I think Range Regiment is a great place to start out. But being a medic overall in military medicine, it can be challenging. But if you do have a kind of drive to get things done, and you can do a lot of cool stuff. Flight medicine is fantastic. There's a lot of great courses, so the military does a pretty good job. If you want to do something more than that, something like PA, go to PA school. The military's PA school is pretty good. They do accept the military, or especially the Army, does do. They accept people who go to civilian PA schools, and you can come in. Sometimes people that have no military experience, they come in directly as a PA. They do have some challenges at learning how to become a well adapted to what the military expects. There are some quirky things about it that sometimes, if you're not really aware of how, because you didn't grow up enlisted, they are like, this doesn't make any sense. And so sometimes people who are really good PAs just don't do that well because they're rated by someone who isn't a military or isn't a medical person. And so that can be somewhat challenging. I plan on continuing my services as a physician. And sometimes people talk poorly about military physicians, and I don't know why. I think they sometimes get more upset at the system than at the individual person. Certainly the system can be challenging, very challenging to work as a military provider. And that's just part of it, but every system has its challenges. I have worked with some of the best and brightest physicians ever, and they've been in the military, and it's just about learning what you want to do. If you want to do trauma care, there's ways to go about that. If you want to work in family medicine, there are ways to go about that. You want to be operational. Military has all sorts of great avenues to be able to do things. So if you have something that you want to do, there's probably something in the military that does that. And but at the same time, I say keep a pretty open mind, especially if you go as a medic.
Awesome.
Yeah. All right. What other questions you got there, Dietrich?
I think that's it. Like, I think you covered. I appreciate you coming on.
I know.
Yeah.
It's tough because I was so just like focused on everything you were saying, just trying to bring in as much as I could. So I know our listeners will feel the same way. It's been amazing conversation. And where can people kind of keep up with you online and see, a lot of the EBM stuff and everything else that you're working on?
So I am on Instagram. It's Fisher81. Same for Twitter, though I'm not on Twitter very much. I'm actually doing some study time right now, so I'm kind of off IG for a little bit. On Facebook, Andrew D. Fisher. There's the St. Fisher Church of Evidence-Based Medicine. That like I said, very smart guys run that. I obviously have say-so in it, but I really don't have much to do with the content that's published. I'm also an admin over at Next Generation Combat Medic. Same for operational medicine. Same. What other groups, pages do I admin? I am the assistant course director for a pre-hospital Reboa course, whole blood and Reboa course called the Raptor course. And like I said, chairman of National Stop the Bleed Month. And I still do a little bit of stuff. I'm on the communications committee for the Special Operations Medical Association. So I'm all about, it's kind of hard not to find me. You really kind of have to just kind of ignore me if you don't want to find me. I'll be happy to answer. People inbox me all the time with questions. I don't mind answering them. I don't mind talking to people. Sometimes I'm a little slow getting back, but it's because medical school is challenging.
No, you've been awesome. Like I was going to tell you, every time I've sent you a question about whatever, you've responded. If I've asked for paperwork, you've sent me documents. So I appreciate that. Appreciate you guiding me and helping me along.
Yeah, well, no problem, man. Again, it's just about sharing the knowledge and just trying to get. I don't want people, like I said, I don't want people to make the same mistakes I did. And if I can help out anyone along that path, then I'm happy to do it.
Absolutely love it. Let's see. Dietrich, I think people should go to medicalgearoutfitters.com and use coupon code civilian medical for any stuff that they need, anything we talked about in this episode. That's where I buy all my stuff. And that is full disclosure, that is Skinny Medic's shop, and you've got good prices. I don't know how you do it.
Yeah, like I said, we're a distributor for North American Rescue and for TAP Med Solutions, like Fisher was talking about. So any of those tourniquets that we mentioned on the show, the hemostatics, we have them for sale.
All right, that's awesome. I think that will do it for this episode. Andrew, thank you very much for being here with us. Skinny Medic, any
Thank you,
final
sir.
parting shots of wisdom for the people?
Drive the speed limit.
All right, that was a parting shot at me. That's not fair.
Find us and subscribe at civmedical.com.